We'll be covering complications of diabetes mellitus in this video. So, first of all, there are certain acute metabolic complications. Acute metabolic complications such as hypoglycemia, diabetic ketoacidosis. Then we have hyperosmolar non-ketonic diabetic coma and lactic acidosis. Then we will cover the long-term complications. In this video, I'll be referring to the long-term complications. In other videos, I'll discuss all these as well. So, long-term complications. In this, first of all, we have certain microvascular complications, which include the retinopathy, nephropathy, neuropathy. Then we have certain macrovascular complications. In macrovascular, we have the atherosclerosis, coronary artery disease, hypertension, peripheral vascular disease. Then we have miscellaneous, such as infection, gastroparesis, arthroplasty or arthropathy, dermopathy, genitourinary dysfunction, then we have some post-ulcer, post-diabetes mellitus ulcer, that is the diabetic foot. So this is basically both neuropathy and vasculopathy and infection. Now I'll be covering all of them one by one in an easy way to understand. So first of all, let's start from the retinopathy. So in retinopathy, diabetic retinopathy, this is referred to as retinitis proliferans. Now it is an advanced type. In this, what happens is there is vitreous humor, as we all know. So in that, hemorrhage occurs. So due to that, there is extreme proliferation of connective tissue, due to which white colored sheets and fibers are laid down. Now due to this, what happens is the retinal detachment occurs by contraction of connective tissue bands. Okay, now we will be now we will be referring to certain non-proliferative lesions. So this was the proliferative lesion. Now we will refer to the non-proliferative. So in non-proliferative, I will discuss them under three headings. The first one is benign. Now in benign, what you see is retinopathy without maculopathy. Okay, now in this, what there will be dilatation of retinal venules and veins. Okay, then what is the treatment? In treatment is that we will do the glycemic control. So glycemic control, as well as avoid smoking, alcohol, maintain the blood pressure and glucose levels. Okay, now coming on to the next stage, which is the pre-malignant stage. So in this is pre-proliferative retinopathy. Now to remember this, you must think of a drum. So as in drum, we remember, just remember the spelling of drums, but U is replaced by A. So basically drums. Okay, drums. Okay, so by D, what we mean is dot, blot, appearance, dot and blot appearance. By R, what I mean is retinal hemorrhage. A stands for AV nipping. Now, AV nipping was also a complication uh, in hypertension, if you remember, right? So, AV nipping, after that, M stands for multiple hard exudates. Then S stands for soft exudates, macular edema, premacular exudates. Now, in this similar treatment, this as well here, mention it again, plus photocoagulation and focal treatment of new vessels to stop leakage from microaneurysm, from microaneurysm and capillaries. Also, injection of an antivascular endothelial growth factor, that is uh, bevacizumab. Okay, this inhibits the growth of new vessels. So basically, it is inhibiting the neovascularization. Now, I told about 3 stages. Now we're done with 2. The next stage is the proliferative retinopathy. In this, what we see is it is basically malignant. So we will see pre-retinal hemorrhage, neovascularization, macular exudates, and fibrosis. Similarly, same criteria: photocoagulation, the control of the diet and all, smoking. Now coming on to the second one, which is the diabetic nephropathy. Now this is very important because this is the most important reason for basically mortality and morbidity in diabetes. Now this usually occurs in type 2 diabetes mellitus. Also it occurs in type 1 diabetes mellitus as an end stage renal disease. Now how does it occur is basically through 2 ways. One is the glomerulosclerosis, which is diffuse, and the another one is by nodular glomerulosclerosis. Now this is more common. Now in this, what happens is there is thickening of basement membrane of glomeruli. Over here what we see is there is material which is pass positive. It is deposited at the periphery of glomerular tufts. This is also called as Kimmel Steele Wilson lesion. Now coming on to the clinical features. In clinical features, we will discuss again 3 stages. The first one being the early phase. In early phase, what we will see is it will be asymptomatic. GFR will be increased. This is basically the hyperfiltration stage. Then after early stage is the renal hypertrophy stage. Now this is going to be symptomatic. Also we will see massive microalbuminuria. Then is the end stage renal disease. In this, basically hypertension and chronic renal failure. Now diagnosis will be through albuminuria and RFTs. Management you can mention about low salt diet, diuretics and all, furosemide, torsemide, bumetanide, then ACE inhibitors, calcium channel blockers. If it reaches the end stage, then we have to give hemodialysis. Okay, now coming on to the third part, which is the neuropathy. Now this is very, very important. Neuropathy, diabetic neuropathy. Now the main pathological changes that occur. To remember these changes, remember vapor but with triple A and no E. Okay, so V stands for vasculopathology, neuropathy. E stands for axonal degeneration of myelinated and non-myelinated fibers. A stands for acute, painful, peripheral neuropathy. Then another A stands for the autonomic neuropathy. P stands for patchy segmental demyelination. R stands for the um, I think retinal. Okay, then R stands for nothing. D stands for diabetic amyotrophy. Okay, just remember waved. Okay, not vapored, waved. Then coming on to the classification. In classification, again we have stages. So first of all, we will discuss about somatic. In somatic, we will discuss about symmetric, sensory, and distal. This is most common. Then signs and symptoms, treatment. In signs and symptoms, what we will see tingling sensation or burning sensation. Tingling and burning sensation in extremities. Then nocturnal pain, numbness, coldness. Then glove and stocking type anesthesia. Charcot joints, these are the hypermobile joints. Charcot joints, loss of peripheral tendon reflexes, abnormal gait. Then nerve conduction velocity is delayed. Nerve conduction velocity delayed in distal parts. So first of all, we will have to have a metabolic control with long-term insulin. Also, we can give antidepressants. Then is the next stage, which is the acute painful stage. Similarly, hypersensitivity, nocturnal pain, physical and emotional distress will lead to pain. Now over here, first of all, we will give tricyclic antidepressants, anticonvulsants, also methylcobalamin. Then third type, it is the asymmetric type, motor type. Now here, lower motor neuron paralysis. Now this was also discussed in one more video. Just remember lower motor neuron paralysis. You should be reminded of dysphagia. It was one of the causes of the motor dysphagia. Okay. Then painful muscle wasting. Now it will occur more in lower limbs. Now over here we can give aldolase reductase inhibitor. Okay, now in mononeuropathy, basically you will see carpal tunnel syndrome, foot drop, and all. Okay, now we discussed all these, then we will discuss some of the miscellaneous ones. So, in autonomic or visceral, so first of all is CVS. In CVS, what you will see is vertigo, giddiness, tachycardia, fixed heart rate, blurring of vision. Then second is GIT. In GIT you will see vomiting, nausea, then gastroparesis. This is important. Nocturnal diarrhea, constipation, and dysphagia. Then genitourinary. In genito, first you will see that there will be male erectile dysfunction, also loss of libido, But in urinary, what you will see is increased continence, atonic, distended bladder, difficulty in micturition. Okay, then another system, pseudomotor and vasomotor. In this, abnormal gustatory sweating, fissuring of feet, anhidrosis, cold extremities, dependent edema. In eye, you will see constriction of pupils. Now over here you can give propanthyline. Here you need to avoid beta blockers. Over here, basically, if you remember pharmacology, papaverine for erectile dysfunction, drugs, pithancol. Okay, then in GIT, we must give mosapride, then tetracycline. Over here, we need to support the treatment, and we can give we can give fludrocortisone. Okay. Then there are certain cutaneous complications as well, such as like boils, carbuncles, okay, diabetic foot, acanthocosis, nigricans, then necrobiosis lipidoca diabeticorum. We can also mention about certain complications which occur during pregnancy. So first of all, maternal risk may there will be abortion, maternal hypertension, infections, preeclampsia, also postpartum bleeding, retinopathy, same, nephropathy, vasculitis. In fetal, what you will see is there will be a macrosomia, then there will be neonatal hypoglycemia, then hypocalcemia, hypomagnesemia, okay, hyperbilirubinemia. So also their growth will be retarded, okay. Preterm babies or preterm labor pain can be felt. So stillbirths, and there will be increase in the mortality. So this basically completes all the complications of diabetes mellitus. I hope you understood. Thanks for watching.